Works. Yeah, well, thank you everyone for joining. Just because I hit record doesn't mean you can't talk or anything like that. But thanks for joining our monthly meeting. Today is Tuesday, June 4th. I'm Palat, the president of CMDA, and this is our monthly CMDA meeting. We're really excited to have you here and to have our incredible speakers, and special today is our annual business meeting. We're going to start off today with talking about registration for death and certification of death. Here is the agenda. I hope you can see it. And we're going to start off with talking about the electronic death registration system. And we do have a couple of speakers from the EDR here to help us out. We also have updates from CHCA and CDPHE. And today we're going to have each of the candidates for the CMDA Executive Board introduce ourselves and then conclude with the annual business meeting. So one thing, just before Carolyn and Michelle start with their part, I just wanted to introduce everyone to this resource that I found. I hope we can share it correctly, but I've been looking into trying to teach people how to pronounce death and certify death correctly. And there is actually an education from the CDC on writing cause of death statements. And they have a website on the CDC that was linked in your last CMDA email. It includes a handbook on medical certification of death. They have a CME that's pretty quick, and you can earn CME for learning how to determine the cause of death, and some other resources on the CMDA, on the CDC website. So I want to make you aware of that. And if you didn't get the email or not sure where to find it, just let me know. But it should be in that last email that you got from CMDA. We also had Carolyn and Michelle help us with some Q&A. And I went ahead and emailed that to the group. So take a look at that. And so that gives us some background for
if you want
the presentation today.
Screen,
so Carolyn and Michelle, we'll go ahead and let you take it away.
Sorry to interrupt just a little bit. This is Michelle again.
Yes.
Caroline's having technical difficulty with Zoom, so I'm just going to go over and help her quick, and we will hopefully have this squared away pretty quick.
Oh, thank you. All right. Well, maybe while you're doing that, when you're ready, you let me know. And I'll go ahead and show the Q&A document that was sent out to CMDA. So if you haven't opened it, this is what it's going to look like. And basically, Michelle and Carolyn helped answer some questions that we sent to them by email that you can start looking at it, like the general updates for the electronic death registration in Colorado, that as of February of 2024, we're at over 90% fully electronic. And they're going to have a few stats for us in a few weeks. It is mandatory to use the electronic death registration because of the Senate bill that passed in 2023. We have 72 hours to sign a death record after the person has died. And we have a couple of CMDA board members too that are working with their staff and clinics to make sure that we meet that 72-hour deadline. So even if a doctor takes some time off, we can still meet the deadline and get it signed correctly. I think Amy and Rebecca both have been working around that. There are a few other questions on that Q&A that you might want to take a look at.
So thank you so much, Sing, and I am ready. Perfect timing. Can you hear me okay?
I can hear you.
Okay, excellent. So my name is Caroline Zanot, and I'm a field liaison with the State Vital Records Office. And thank you for having me and for inviting us and for doing a little summary of those excellent questions that you had sent me. So I was hoping to share my screen here and just do like a little demo. Hopefully there's people on this call who are physicians or support staff who would sign or help sign death records in the electronic death registration system. So let me go ahead and share my screen.
And Carolyn, I wonder if you could even
Mm.
tell us like what office you work in, so we understand where you are in the health department.
Sure. Yeah. So Colorado Department of Public Health and Environment, and within that, I am in vital statistics or vital records, and I am one of the field liaisons. So does that answer your question?
Yeah, great.
Okay. If we had more time, I was like, I could show a whole, what do you call those trees?
Organization.
Okay. Let's see. Well, I did. Okay, can you guys see the Cove's login page with the colors?
Yes, that's what we're looking at.
Okay, sounds good. So, yeah, as Singh said, there was a bill that passed in the 2023 Colorado Assembly that mandates the use of the electronic death registration system for physicians who sign death records. And so I thought I would drop in this chat the link to request an account if you sign death records and don't already have an account. I can also email this to Singh or anybody else after this meeting. Okay, so basically, once you request an account, that's going to come to the State Vital Records Office, and we're going to work with the Governor's Office of Information Technology to get your account set up. And once that's set up, we will email you your login credentials and some cheat sheets on just sort of how to use the system. Assuming you can still see my login page here, you can also see at the bottom some help or contact information. There's a phone number here and an email if you have any technical questions. I can also put my email address in this chat if you would also like to email me directly. Okay, so once your account is set up, a funeral home might assign a death record to you through this system, and you would know that one has been assigned to you because you'll receive an email notification to the email address that you put on that system access request form. And again, the system access request form is in the chat of this meeting if you don't have an account. So then an example of what this, can you guys see this PDF that I have? The medical designation, no reply.
Yes.
Okay, perfect. So this is just an example of what this email is going to look like. Subject, medical designation, no reply from our vendor Genesis. And this says you have 48 hours to complete a death record. You actually have 72. The law has since been updated. So you have 72 hours to sign the death record from the time it has been designated to you by the funeral home. So say 72 hours from the time you receive this email notification, and you can see the name of the funeral home, which is the demographic verifier location. Medical certifier location would be you, whatever location you put on your system access request form, and then EDR, which would be the electronic death record number. And then you can see, please visit the URL, which is the website that I have behind this. This is the Cove's homepage. So you're going to go ahead and click secure login. And like I said, once your account has been set up, we will email you your login credentials. And let's see. Now this is our test site. So it's going to let me right in once I enter my username and password. In the live site, we have to do two-factor authentication. Most websites have that at this point. So you could choose to receive a two-factor authentication code to your email on file, or there's an option for like a Google Authenticator app. If you have the storage space on your phone, I don't. So I always opt for the email two-factor code. So when you log in, most of you guys are just going to have one location to select from. If you put multiple locations on your system access request form, you're going to have multiple locations here. Whatever medical certifier location was listed on this email, that's going to be the one that you'll select from the dropdown. Again, this is just a test site, so I'm going to do test physician office name. And now to access the death record that has been assigned to me, I'm going to click death, the death module up here in the top left. And then I'm going to go function and medical data entry. Okay, so death, function, medical data entry. And there are two ways to open the death record that has been assigned to me. So I can open this drop-down menu for the unresolved work queue. This is going to be the test record Cleo Mori that I will be completing for you guys. There might be multiple records in this unresolved work queue. That doesn't mean they're all assigned to you, because all physicians under the same location name would have access to those records. Hence, when Singh mentioned earlier, you can sign for each other if some of you are in or out of town. The other way, say you don't know your patient name, say that you met them one time for an hour, and there's a whole list here, then you can search the EDR name. So the EDR number, which again was in this email notification that you received when the death record was assigned to you. So to search by the EDR number, you can click on the binoculars in the top left, and then you don't have to enter all this search criteria. You could just enter the EDR number and then click search. And then obviously I entered a made up number, no results returned, but you would enter your EDR number and it would show in this little table at the bottom, and then you can open it from there. Okay, so I'm gonna go ahead and just open it from the unresolved work queue, and I can verify that this is my record. I can go to the medical COD tab, and I'm going to scroll down, and under certifier information, I see my name, okay? And I can see my information here, that my address, all this information that I put on my system access request form. So these tabs, decedent, residence resident relations, race, education, disposition, those are all completed by the funeral home. Those are all demographic fields. So as the physician, 9 times out of 10, you're only going to fill out the medical COD page. Medical injury is more so with coroners or medical examiners. It's unusual that you would need to fill out the medical injury page. So really, you're going to open the record, and almost always you can just go straight to the medical COD page. And I apologize if I'm moving a little fast, but I think I've only got about 7 more minutes or so. So for medical COD page, I'm just going to work my way down the page. Time of death type. You can see a bunch of options for approximate. Maybe it's unknown, probable. I'll say early AM. Let's see, that populated. I'll do actual time of death. And I like to use the tab key on my keyboard because it moves me from field to field. And if you use your mouse, sometimes the fields don't light up in the correct order, and it can things can get a little glitchy. So I recommend using the tab key to navigate field to field. So let's see. And then time indicator would be AM, PM, or military. We have no preference. And then date pronounced. The funeral home would have also indicated that on the decedent tab, if you don't know it. So decedent, the funeral home puts date of death 6/3/2024, and I agree with that. So I'm just going to go ahead and put that down. Time pronounced. Was an autopsy performed? In most cases, if you're assigned to the record, the answer will be no. And then it's going to ask, did tobacco use contribute to death? We collect this information for statistical purposes. It helps inform like public health initiatives. So we'll say no. Manner of death. Again, if it's assigned to you as the physician, it's almost always going to be natural. These other options are more so if a coroner or medical examiner is involved. All right, so getting down to the cause of death fields. So this is where you're going to enter the chain of events and that directly cause death in reverse chronological order. please don't enter abbreviations. So the immediate cause, which was say like the final disease or condition resulting in death, could say acute renal failure. And now the interval to the right lit up. And this is the intervals refer to like the proximate interval time, like onset to death. So this could be minutes, or this could just be days, or I could be very specific and I could write 3 days, you could also write unknown, okay? But you have to put something in the interval field if you have a cause to the left of it. So I will say 6 days. Cause B. So again, sequentially list conditions, if any, that led to the cause of death listed in line A. So I could say okay, and maybe we say 3 months. And now for the underlying cause, I'll say, okay. And interval C, we'll say 7 years. And again, with the tab key, cause D is going to be lit up unless you at least acknowledge it. You don't have to put anything in all of these causes, but you kind of want to resolve the field. The system wants to make sure you don't forget anything. So I tab through it. It didn't require an interval for it. Okay, now part 2, other significant conditions that say contributed to death, but did not result in the underlying cause given above. So yeah, I won't put anything in here, but examples could be, smoking or elevated like blood alcohol content, or maybe COPD, stuff like that. Okay, so now for certifier information, this is all pre-populated. Date certifier signed. I can't manually enter that date, but that will populate once I sign the record, which is the next step. So I'm just going to save my work. And this is just sort of that's just sort of like a test site glitchy notice. So you should not get that little pop-up when you click save. And now to sign the record, the top of your page, you're going to open the registration drop-down menu, select medical certification. And in the same email where we send you your username and password, we'll send you a PIN number. And now the PIN number is unique to you, it won't change, and it's only for physicians. So we don't give PIN numbers to any support staff who might help data enter records. So please do not share this PIN number with anybody. And it's your unique identifier. So I entered my PIN number and I'm going to click OK. And it's going to ask, are you sure you are ready to certify the record? Yes. Record certified successfully. So now, medical COD, you can see that date certifier signed is now populated. It is still sitting in my unresolved queue, but I completed my portion and the funeral home just has to release it. So that is the demo. I think we are ending right on time. So I don't know what you got. I missed the agenda as I was looking at my screen earlier, but I can go ahead and hand it back off to you, Sing.
Oh, thank you, Caroline. Appreciate that. I like how it doesn't let you sign unless you've done your required parts. So I always feel confident at that point.
Yes.
Yeah. Amy and Rebecca, any comments?
Hey, Sing, it's Amy. Can you hear me?
Yes, thank you.
I appreciate you guys taking time to talk about this topic. So I just want to let you know what our office has done. So to cover vacations, our office has designated a generic inbox for all death certificates. And then the office manager or her designee will supervise that inbox. And in that inbox, the death certificates come labeled by physician. So she'll see Amy Moeller has a death certificate. If she knows that I'm going to be out of the office for greater than 72 hours, then she will assign it to another physician. So that's what our office has done with the help of Caroline's office. That's a system we set up to cover the vacations.
Has that been going well, or have you had a chance to assign other people?
As far as I know, it's going well. The generic email catch-all just went live about 2 weeks ago, and so far so good. I haven't heard any glitches yet. If I do, I'll let you know, and I would love to hear how other groups are solving the 72-hour issue.
What I meant to say, I hope you've had a chance to go on vacation so you could test.
Oh,
Yeah.
you're too sweet. I have not, but I'm leaving next Thursday, so we'll see.
And this is Rebecca. Hopefully you guys can hear me okay.
Yes.
We use a similar system. So we use that exact same system, and we actually have MAs that kind of support us in our remote office. And so they also help find some of the data, like the time of death, because sometimes that can be a little bit challenging to hunt down in the facilities records. So they also help data mine a little bit for us, and then we fill in the remainder of it with the cause of death. And it works really well. Like, we've been using it for a few years, and it most definitely beats the days of like the poor funeral homes having to like hunt us down for signatures. So I think it's a great option. And this was really helpful because there were some functionalities that I didn't even know about. So I appreciate you guys running through that.
Cool, thank you.
Yeah. Yeah, and Rebecca, this is Amy. What I do for the time of death also, because when it was on paper, the death certificates used to pre-populate that, but they don't anymore. So
Yeah.
I just put it in the comment section to the funeral home and just say, please send me the time of death. And they do. They're pretty good. I haven't, as Caroline presented, I haven't found it under the decedent tab for my funeral homes.
Yeah, maybe it depends on how much the funeral director helps you out with some of that data mining.
Yeah, we actually have our MAs go into the EMRs at the facilities if we can't find it. So
the date of death would be in the demographic tabs.
Yes.
The time of death would not be, as you said.
Oh, okay.
So you could reach out to the funeral home. You could leave a little comment. You could click on this comments button.
Yeah, that's what
it
I
does
did.
not email the funeral home though. So you are taking a chance that they are regularly monitoring this inbox, which they probably are.
Yeah.
But that's just something to be aware of.
Yeah, and honestly, after doing it for a while, here in my location, I kind of now have the funeral homes trained. So they just put it in the comment section. It's rare now I have to ask them for it because I was asking for it and, like you say, creating more work for them. So now they're just doing it.
Wonderful. Thank you for sharing your experiences.
Yeah, again, thanks for talking about this thing.
You bet. Yep. And I'm glad that we have you as a resource, Carolyn and Michelle. Looks like Dr. Weaver might be reaching out to you. Are there any other questions? Okay. Thank you so much for the demo. We will move on to the next item on our agenda. And I'm actually going to go straight to Chad Fear because I think you're here live. And that might be really nice to hear your update, Chad. If you're talking, we can't hear you yet.
Now?
Oh, we can hear you now.
Oh, my computer only seems to like Google Meets.
Ah, sorry. We're
Yeah,
a
no.
Zoom group.
No, I just a few things. I had shared some information at the CHCA spring conference, and I thought I would bring some of that information and share with you. Presently, we have 6 facilities that are in our recertification backlog. We feel accomplished in being able to resolve this backlog. Going back several years, we started at like 108 facilities that were overdue because of the work pause that was created. If you recall, in 2000 and 2001, we had work pauses because our efforts were focused around doing infection control inspections, providing infection control support. So in getting that resolved, our challenge has been we've had to concurrent with all of the other facilities that were current. So it's been something of a monumental task for us, and just working through our own staffing issues as well. But we're down to 6, and those will be resolved shortly. Yeah, my handwriting is a challenge. I'm sorry. Yeah, and so in order to get that done, we've had a few facilities that have gone slightly overdue. It's possible that we're going to get some more contract survey help in order to catch us back up. Overdue is anything over 15.9 months since the previous recertification survey exit. So we have that deadline, but we also have to achieve a 12.9-month average amongst all facilities with recertifications. So we're working to, of course, resolve the backlog, but then to get our average time from previous survey back from about 17 to 18 months right now, and getting that back to the 12.9 months. And business as usual, pre-COVID is what our goal is. We just in looking at some of this information, I have lists of frequently cited, most commonly cited areas of deficient practice, and you can guess that it's going to be those areas that there's multiple ways to not meet requirements. Infection control, sanitary food service, accidents. Those are kind of the headliners when it comes to that. ADL care for dependent residents. A lot of different things go into that. So we see those as a trend, not only for Colorado, but for across the nation. When comparing our findings with what's going on across the nation, they're very similar. Did want to mention the
Chad, looks like you're on mute. You said you were about to mention something and then, oop, the sound went away.
Yeah, it must be a gremlin. What the heck? Anyway, sorry about that. Just to mention some of the immediate jeopardy situations, things that you may want to look at in your own facilities in terms of patterns and process systems. We tend to see it when it comes to pressure-related skin conditions, non-pressure related skin conditions, accidents, smoking, drug regimen review. There was a recent immediate jeopardy situation, and unfortunately the reports from the consulting pharmacists were not making their way from the facility to the prescribing physician or the attending physician, so that there were any feedback or any changes based on the recommendations for identified irregularities, that those weren't making those to the physician, and therefore created a situation where a serious outcome was likely, based on the type of life-saving medications that some of those reviews were including. You know, the minimum staffing standards were filed in the Federal Registry on May 10th with an intended effective date of June 21st. And AHCA has filed a lawsuit. So I believe that was on May 24th. So even though we have some requirements around those, the minimum staffing standards in terms of regulatory compliance and the implementation of all of that, the lawsuit will need to be settled, of course, before then. You know, the main thing that really kind of jumped out with that, and at least in terms of the immediate future, was the enhanced facility assessment and looking at how we've determined, you know, the needs of residents and the resources of the facility to meet those needs. One of those resources, of course, being staffing, based upon the acuity of the, you know, the population that the facilities are serving. And, you know, we look at that anyway. You know, there's an emphasis here that it's reviewed. I think there's an inclusion and incorporation of people outside of the facility, like residents and representatives, in really pulling this together, that it's a you know, a broader approach to determining the needs of the residents and the services available through the facility. But because we're looking at that anyway, and we're learning more about the requirements around that, and you know, there's a great connection, a natural relationship between the facility assessment and the emergency preparedness plan, and identifying the needs of your residents and building your emergency responses around those specific needs. So there is a natural relationship there. So we look at this stuff anyway. Lawsuit or not, the implementation of a lot of this stuff was protracted out over the course of, you know, 2 to 5 years, depending on whether a facility is rural or not rural. So we're you know, we're at the point where we're just going to wait and see what happens. And then some other things that we've been working through. You know, we've received over the enhanced barrier precaution requirement, with that being included now in F880 as part of the regulation, looking at just kind of those what if scenarios and what if situations, like for example, a therapist is helping a person ambulate down the hall as a part of therapy. Would enhanced barrier precautions be required in that situation? And a lot of the conversation around that is it's about the close contact, and close contact leading to increased risk of transmission. So in this particular situation, unless there was something that required a close contact, excuse me, gowns and gloves would not be required in that situation. So there's a lot out there. We're still trying to wrap our heads around when they would apply and when it would not apply. Even things as simple as where do you store the PPE? Is it stored in the hallway? Or can you store it in the room? And you can store it in the room. The only thing is, once you store it in the room, it can only be used for that resident. So it cannot be taken from the room and used elsewhere where you know, PPE is required. So there's you know, there's going to be some information around that. I have an FAQ from CMS, Alphabet Soup. I'm not allowed to release it quite yet, but at some point, if we do not get the permission to release it, I think we'll just start having discussions around the questions that were included in that FAQ that was shared with us, and just the response that surveyors will be taking when identifying those situations. But that is what I have for you all today. Are there any questions?
No, thank you, Chad. Really
All right.
appreciate that. Yep. I was on the recent CDC call that the CDPHE brought to us about enhanced barrier precautions. And it did seem like they were alluding to that CDC and CMS may have a little slightly different expectations at times. So that'll be very curious when you have that available for us.
Yes, and you know, that's a great point, because our regulatory actions are guided by CMS. So if there's a discrepancy between the CDC and CMS, we're going to follow up from that regulatory perspective with that guidance from CMS, excuse me.
Thank you. Dr. Reitman, you have your hand up? We can't hear you though, because it looks like you're on mute.
Hey,
Oh,
can you
now
hear
we
me
can-
now? I just wonder what the status of minimum staffing requirements is. Is there any movement to make this become the standard of care, or is this still in lawsuit territory?
It is AHCA. So Jenny's National Parent Group filed a lawsuit on May 24th. You know, against the recommendations, or the requirements rather, I shouldn't say recommendations. So that's still left to be played out. And from our perspective, from the surveyor's perspective, we're already looking at the facility assessment, and that was the only thing that needed to be addressed within the next 90 days. So in terms of any terms of immediacy from our standpoint, it's stuff we're looking at anyway. The other stuff, we'll just have to wait and see how that lawsuit plays out.
Thank you for mentioning that.
Okay.
Appreciate it. Well, speaking of CHCA and AHCA, Jenny Albertson normally would give us an update from CHCA. She has prepared a recording for us that I will play at the end of today's meeting. I'd like to focus on the people who are here first. So our next item on our agenda is to talk about the CMDA Executive Board for this coming year. Am I showing the, oops, not yet. I'm trying to show the list of candidates for our officers. And Dr. Leslie Eber, AMDA Vice President, CMDA Immediate Past President, is going to go ahead and introduce us through this part.
Thank you, Singh. Thanks
You
to
want me to
everybody
leave this up?
who, I'm sorry?
Would you like me to leave the list up?
Yes, please. So we'll go through each of the candidates and let them speak to us and let us know what their thoughts are and share a little bit about themselves. And we'll start off with David Shepard, who is running for treasurer. David?
Yeah. Hello, guys. Can you hear me okay?
Yep.
Yeah. So for those of you I've met, I'm Dave Shepard. I'm an internal medicine physician and a medical director in Colorado Springs. I also have several buildings in Eastern Colorado where I'm medical director, and some of those rural buildings present interesting opportunities and sometimes challenges. I spend most of my time now in the medical director role, but I still keep a small patient panel, mainly because I enjoy practicing medicine. And I also think it's important to continue to see patients. That way I have an inside view into the care that the patients receive at the facilities. And my interests lie in process improvement, antibiotic stewardship, polypharmacy, and more recently, diagnostic stewardship. And I'm not going to get on my soapbox about urine PCR testing, but that's where that interest came from. I initially joined AMDA because I needed educational resources, but I quickly found our state chapter, and I found a group of people that has kind of become my tribe. I feel like it's a group of people that help each other learn, help each other understand, help each other solve problems. I've also been very lucky to have had mentors through the CMDA that have been important for my growth and my development and running ideas off, and sometimes my sanity just to vent with. So if I can give back to this group, I really want to do so. It's certainly made me a better clinician, medical director, and probably a better person. So yeah, I would enjoy being treasurer and continuing my role with CMDA.
Thank you so much, David. So well spoken. And next we have Dr. Rebecca Jackson, who is running for Vice President. Rebecca, would you like to share some words with us?
Sure. So for those of you who I haven't met, I'm a geriatrician and a medical director up in Fort Collins. I'm currently working for a Northern Colorado hospice group in our Health Partners division. I'm the ACMO for them, and I help our group who serves, all realms of post-acute care. We see people in home, ILF, ALF, SNF. We're doing acute rehab now, and I can't say enough about AMDA and CMDA. They've really been my professional home, and I'm just really grateful for this team and really enjoyed working with them more in the last few years. And so I'm learning more about this vice president role and helping sing, and I'm the group, and I'm just, interested in continuing that for the next year. So.
Thank you so much. And next, Dr. Chris Horton is running for Educational Coordinator. I'll turn it over to you, Chris.
Hi, hi everyone. Those are really tough to follow, Dr. Shepard and Rebecca Jackson. I think I've been on the board for 3 or 4 years, and prior to that, though, I routinely attended the meetings because I felt like these are very important and very educational meetings. But what I really want to stress, whoever's education coordinator, this organization is really to serve you and the community. And so we really appreciate your input. And so we really want to hear from you guys what you're seeing and what's important and what you want us to provide you with education on. So if you haven't reached out, or if you have ideas, please reach out to us and let us know what we can help you with, that you're struggling with, or that you'd like to learn more about.
Thank you, Chris. We have such a strong panel, so we're grateful to you all. Next, we'll hear from Allison Villegas for Community Liaison. Thank you.
Hello, everyone. I'm Allison. I'm a PA in the Denver metro area, worked in post-acute and long-term care for my entire career. I've been on the board for the past few years. So looking forward, hopefully, to serve as community liaison. This will be a slightly different role than I've done before, but I look forward to kind of help bridging the gaps in between the different practice groups and making sure that we're communicating within ourselves and with the CMDA board.
Thank you so much, Allison. You bring such a wealth of knowledge. And then finally, but certainly not least, we have the honor of introducing Dr. Singh Palat, who is running for president. Singh?
Thank you, Leslie. I would love to be the president for at least 1 more year. Singh Palat. I'm an internist and geriatrician here in Denver. And before I was president, I was the treasurer. So I've been here with CMDA well, actually, I was the vice president. And then before that, I was the treasurer. There was a sequence to it. And I'm so glad to have been with CMDA for many years. And sort of like David, I think I started initially for the education, but now I find it's so meaningful and rare and unique to also have a community of people that I can rely on and reach out to. I love working in the post-acute and long-term care setting. Last week, I was volunteering to play the piano in one of the long-term care facilities here in Denver. And while the music was fun and playing for the residents was great, the activities director, she said she was so grateful that just for an hour, she didn't have to do anything. It was just a nice way to help out. And I think that in these communities where we work, just bringing our expertise and bringing our compassion can go so far. And so it is very meaningful for me. And I'm grateful to be part of this space and grateful to be here with you at CMDA.
Thank you so much, Singh. I want to thank, on behalf of our community, thank you all for running for these positions and taking on this leadership. I couldn't be more proud, and I feel more lucky to have you all lead our community. So you will be receiving a ballot, and if you are a member, then you can vote. So please become a member. It's really not very expensive, and we are grateful. Becoming a member not only allows you to vote in this election for these really remarkable providers, but also supports our annual conference, allows us to bring in speakers and help our community. So please look for that in your email. And Sing, how long will people be able to vote for?
I was going to leave the polls open until Friday at noon.
Well, thank you, everyone, and I'll turn it back to Sing.
Yeah, thank you, Leslie. Wonderful. And we appreciate you, Leslie, for building our community the way you have. And we couldn't have a president without having an immediate past president. So thank you so much for staying on with your role. Well, we are going to have our annual business meeting at this time. And Travis Neill, you'll notice he was not on the ballots. He has been diligently serving CMDA as our treasurer for the last few years. He has done a wonderful job. I think you're going to hear a lot of successes in today's report from Travis. And unfortunately, he's going to be stepping down from that role. But fortunately, we have David Shepard to take over. So Travis, why don't you go ahead?
Thank you, Sing. I appreciate that. Can you hear me okay?
Yes.
Okay. Yeah, and thank you. I've been on the board since 2018. Both Allison and I joined at the same time. That's 6 years. So it's definitely been an incredible honor and part of my professional career to, feel a part of a family and really to be able to be really engaged and connected with this community. So it's been great, and I just felt like it was time to make room for new blood. So I'm going to go over a couple of financials. I'm probably one of the few people that enjoy spreadsheets, so I'm under no delusion that this will be exciting for everybody, but feel free to ask questions, and we're going to do a quick review of the annual meeting profit and loss statement and then our financials for the last 4 years. So the 2024 annual meeting was, I think, another fantastic success. The overall financials are that we profited this year. If you remember, we did not profit last year, which was for a variety of reasons. Our goal isn't to make a lot of profit. It's just to remain financially stable so that we can use the money for all different kinds of educational opportunities. But this year, the annual meeting came out with a $13,000 profit. And that definitely helped from the previous year when we had a small loss. And then if you can see this here, see if you can see the screen better that way. So this is the CMDA income statement from 2021 to 2024. And I took out 2020 just because it was a very strange year. In fact, I've pretty much eliminated 2020 from my entire memory. So, but this provides a nice year-over-year comparison, just showing really how we spend our money, and that we have remained financially solvent. We currently have over $40,000 in the bank. As a nonprofit, our goal is to use this money, and so that is really the overriding theme of any kind of financial discussion, is how to use the money. So to piggyback on what Dr. Horton said is, we really look for input from the community, anyone and everyone, for ideas and ways to really forward our mission, which is education and interest in sort of the connectedness of the community. Outreach to rural facilities has always been something we discuss. But we're looking for essentially any ideas people have. We're going to send a poll out after the meeting, and one of the questions in the poll is an opportunity to come, respond with ideas, but feel free to email, or if you want to speak up today, you can as well. So, we carry about anywhere from $30,000 to $40,000 balance at any given time. Right after the annual meeting is when we're most flush, so to speak. But we've always sort of struggled with how much to carry, and it's, I've always contended it felt like a little much. And so I think as a board, we've always really just encouraged more ideas. So that is the overriding theme. If anybody has any questions, you can feel free to ask, and otherwise you can use the poll, or you can use an email to Sang or anyone on the board for any ideas you have.
I wonder, Travis, if you want to just leave it on that expenses view. To me, that's just a wonderful overview of things that we do throughout the year besides the conference and where we've been spending our money. And that's what we're looking to get new ideas for, isn't it? That part of the statement.
Yeah, I mean, we fund the futures program. We usually donate to that. We try to support specific futures candidate if they want to travel out to the AMDA conference. We try to support at least the board going to the AMDA conference, and various smaller items, I think, to encourage more connecting. And at the AMDA conference, we also support kind of a social with other chapters, which is again another opportunity for us to communicate with each other. So that is kind of the gist of it. And then the annual meeting is the biggest expense that we have.
Thank you so much for that overview, Travis. Are there any questions or suggestions from the audience? Well, we are happy to take your input anytime, year-round. Again, thank you so much, Travis, for everything you have brought to CMDA, and for keeping us organized, keeping us solvent, and keeping us laughing too. Thank you, Valerie. Thanks for your comment about scholarships. I think scholarships might be a great thing for us to look into. So I welcome your future ideas about that.
Well, you know, I am a little biased, so because I keep going.
Well, we want to help people out if we can.
Right.
Get more people, that's part of workforce development. Okay, well, thank you so much, Travis. If there aren't any other comments, I'm going to go ahead and finish this meeting by presenting the CHCA update, which is a pre-recorded video from Jenny. It'll probably go over the hour, but it will be part of this recording of today's meeting, and we'll make sure to send it out to everyone on our distribution list. So please enjoy this update from CHCA, if I can play it. And I'm going to do my best to do that right now.
Good morning, everyone. All my friends at CMDA. I'm sorry I can't be there with you today. I guess for you it'll be noon.
Sorry, I don't think I was sharing the sound. Let me try again.
Well, we could hear the sound. Okay.
You could? Oh, okay.
Yeah.
Okay, good. Thank you. All right. I was a little worried about that. Thank you.
Good morning, everyone. All my friends at CMDA. I'm sorry I can't be there with you today. I guess for you it'll be noon. I am recording this for you from Washington, D.C. at our congressional briefing. And I didn't want to forego giving you an update, because part of why we're here is, of course, to meet with our legislators with regard to the mandatory staffing concern, the mandate that is coming out. And so I wanted to give you a couple of statistics that we're presenting to them, and also give you a little bit of news you can use as usual, with a little bit of education spiced in there, as I always do. So to give this to you as a point of reference, both for your own understanding and for you to share with others, we are advocating for the removal of the mandatory staffing mandate, both through congressional action, and also ACA, our national affiliate, has now placed a lawsuit in Texas with our Texas affiliate and several providers against CMS and the Biden administration about the staffing mandate, basically contesting that there is not a proper pathway for CMS to institute this legally. It has to be done through Congress, which was actually denied when it was presented a couple of years ago at the beginning of the Biden administration. So at any rate, this is what we are basing some of our discussion on today. There's some statistics here for you. This shows you how limited our admissions are based on workforce currently as of June 2023. So I guess it's a year old now, but it's relatively the same at this point. And then potential for closures. This brings home some of that threat with the national picture here of 579. It's now up to 600 nursing homes that have closed nationwide. And this is a Colorado picture for you to see how many of our current nursing homes can actually meet the present requirements that are presented in the staffing mandate. Shows you how much of a deficit we are at, but more importantly, I think, for our rural communities, this slide compares urban versus rural and shows you how far of a reach it will be for us to comply with this requirement. So it's going to be a major challenge and will likely result in some closures and some fines if we can't get workforce built up within 2 years, which I think is a definitely something that we would like, but definitely a far reach and probably not attainable. So, and then the number of staff members needed, this just breaks it down. This is current image for all requirements. So the majority of our loss is in nurse aides and need. We actually do have quite a few RNs in Colorado simply because we have always had, well, not always, but for the last several years, we've had a 24/7 RN requirement in skilled nursing that can be waived with the state, but we exceed the national mandate in RN requirement. So that explains why that might be not as difficult to reach. And then let's get into some news you can use. I wanted to bring this to your attention. There is some legislation pending that would make methadone for substance use disorder more attainable for people outside of clinics. So this would allow board certified addiction doctors and addiction psychiatrists to prescribe the medication directly to patients without going through clinic monitoring. This is important to us simply because it liberalizes methadone as a treatment for substance use disorder and sets the stage for us to potentially have it more accessible in our environments as well. If it does not have to be monitored with drug testing and all of the things that happen within a clinic, then potentially that could be something that is expected of us with substance use disorder treatment for our residents. So I'm watching this legislation. We'll see what happens with it. The care transitions information meetings that are coming out are going to come to your attention, I'm sure, primarily because some of our social workers are, and maybe you, are concerned about how the Medicaid program coming into our facilities to announce that people can leave and be deinstitutionalized might ruffle a few feathers. People that are stable in their nursing home setting but long to be independent again may be disrupted by this and re-traumatized. So if that comes to your attention and you're concerned, please bring this forward to the people that are arranging in your building for these care transition meetings. We are mandated to hold these meetings. Medicaid is intending to deinstitutionalize as often as possible. I think I've spoken with you about this before. In Colorado, we're really pushing home health and lesser levels of care beyond nursing home. And so they are making these in-reach meetings a mandatory enterprise, and it's going to probably disrupt some people. So please communicate with your staff if you're concerned about that, so that those folks can hopefully be left out of the meetings so that they are not re-traumatized. Here's the education piece. There was an article recently that came out in McKnight's, I've linked it here, talking about the term plateauing for rehab potential. And I do get this question from medical directors, so I wanted to bring this to your attention. Plateau is actually not something that we strive for. When someone is no longer improving, that does not mean that they do not qualify for Medicare skilled care. So I wanted to clarify, there was a lawsuit in 2013 called Jimmo versus Sebelius that alleged that Medicare contractors, us as providers, were inappropriately applying an improvement standard, that really people that are under nursing home care should qualify instead based upon the appropriateness, medical appropriateness for ongoing benefit, not improvement potential. So if you look at the Medicare manual excerpt in the first bullet, it tells you very clearly coverage of nursing care and or therapy to perform a maintenance program does not turn on the presence or absence of an individual's potential for improvement from the nursing care and or therapy, but rather on their need for skilled care. So I hope that is helpful to you. If you want further explanation of that, I've done a little bit of rabbit holing on this issue for medical directors in the past, and I'm happy to share further information. But the article is a great summary of why this makes sense under Medicare guidelines. This is just a blurb to make you aware. If you are seeing black metal bed rails in your nursing homes or assist rails, chances are they might be Medline bed rails that have been recalled. So this is a very recent May 30th alert that we are to remove bed rails or assist bars that have the model numbers that you see below here, MDS 6800BA and BAH. They're only named differently because of how they were packaged and sold. This is the link to the press release from Medline. And essentially there was entrapment that was happening between bed rail and mattress, and it resulted in 2 deaths. And so they've recalled these items. So be aware of that if you see those in your home. And by the way, bed rails are really frowned upon by CMS because of this risk. And also in Colorado, we've had some horrible degloving incidents. And so if you have someone using bed rails or advocating for the use of bed rails in your home, often it's family members because they use them in the hospitals and they think it's a safety measure. Please send them my way, and I'm happy to outline for them not only the risks, but also all of the steps that one has to take in order to make sure of compliance is appropriately in place with documentation and screening and so forth to make sure you meet CMS guidelines because they're pretty strict. And then upcoming events, I thought you might want to be aware of this more for your people, but also for yourselves. There's an abuse prevention and reporting training that I jointly host with Chad on June 11th, and that is a kind of a big shindig. There's always a lot of people there, and we invite people from APS and the Ombudsman program, and sometimes police will attend as well from the law enforcement side to talk about the elder abuse reporting standards and why we are kind of threading a needle when it comes to abuse reporting and behavior management in our environments, with pleasing all of the masters that we have under all the legal standards. Also, CNAs are going to be highlighted for a conference on June 21st. We're hosting an educational conference for them. It's a great way to really encourage people that are leaders in your communities. Send them to us, and we will spend a day supporting them and educating them through the CNA conference. Encourage your facilities to do that, please. They deserve to have some retreat as well. We are taking the abuse prevention training on the road. July 18th, there will be an abuse prevention and behavior management in-person workshop hosted by me and Chad. This is not quite the same as the one in Denver because we don't make it a cross-disciplinary with APS, Ombudsman, et cetera, but it is a regulatory review and it's strategies and a workshop to really help people avoid abuse incidents, primarily resident to resident in their homes. And I think that is all that I wanted to cover with you today. I tried to be quick. Thank you so much for your time and attention. And I do miss being there today, but I'll be happily presenting our case on the Hill. Thank you so much.
As always, we thank Jenny Albertson and CHCA for the updates and for representing us. Are there any last comments or questions? All right, well, I think we are done. Thank you so much for joining today's monthly meeting. We will not have a meeting in July because of the 4th of July, so we'll see you in August. Thank you very much.
Thanks, Sing.
Just a quick question. I just wanted to